counseling.
So let's go to the second scenario now. Sorry. To show that this is real. We had an 88-year-old female. She came to the hospital, shortness of breath, altered state of consciousness. The family was persistent that we go for full care. We intubated her. She's on maximum supports. We even dialyzed her. Now she's hemodynamically unstable. She's on triple inotropes. She's having recurrent ventricular arrhythmia. We shocked her twice. And now the problem here is, as we spoke earlier, one family member wants to withdraw, the other wants to still continue. So how can we approach this, and how can we counsel the family that seem to be in denial, and who should be the decision maker? We discussed that already. And how can we talk to the family about withdrawal at this point?
Okay, for this again, I would like, if this is a scenario, we'll have to sit with both of the members. And if any of other members, like his husband or someone those who just want to sit with them, they should sit. And a couple of physicians. Best would be a team, like a critical care physician, a general physician, or a cardiologist who is taking care of the patient. You'll have to tell them in detail that the patient is 88 years old with multiple co-morbid's and she is here and she has been shocked twice. You can give certain data, like talk about in hospital cardiac arrest, survival is 15%. Old geriatric patient, it's hardly 10%. And in ICU setting, after a couple of CPRs, only 3% who can make it. So you have to present them with some of the data. And then, as I said, it is not just going to be a single session. So brief them and let them decide among themselves, give them a few hours, and then they can come back to you and then again readdress. If both of them still they are on the same page, then it's fine. Whatever path they decide, we can proceed with that. But still, if they are in a confusional state or denial state, that one is for the favor of full support and the other is in the withdrawal of the support. So I think in this particular scenario, we'll have to continue with this. The other, this other guy may take you to the court later on. That's what I think.
So my only follow-up on this would be, like you said, we're actively defibrillating her. 3 cycles done, she's not coming back. She keeps going into arrhythmias. How long should we continue our CPR and therapy?
I think legally speaking, I would say continue with the treatment because you have an active conflict there. The stats don't look good. I think she's going to meet her favor pretty soon. So don't try to take the entire scenario. Try to be an arbitrator between the wishes and your treating from your staff and the wishes of the family. Now there's a conflict there. What you need to do is give them clear medical point of view as you see it. No sugarcoating it, just say it and let them decide for themselves. Like doctor said, it's not going to be one session, but you're not in any rush to pull the plug, so to speak. So let the nature take its course. Do not ever take matters in your hand, legally speaking, when there's a conflict in the family. Let the God and nature take its course. So wait and see. Do not rush into the decision.
Do not take matter into hands anyway. I don't have the right to take matters into my own hands about somebody's life. I would be horrified if I took medicine and I could the person died when that is on me. How would I? This is my belief. It's not yours, it's not his. My personal belief as a treating physician would also come into it. I don't want to switch off anybody's life unnecessarily. I have to answer for that. That's my belief. So I don't think you can take the role of God in these situations and decide as a physician that this is enough and I'm going to do that. It has to be medical knowledge based and it has to be consent of the family. It may also be consent of other people with you. There may be other views in your own department, other colleagues who are with you as to how to treat and manage this patient. But Alexander is right, if there is a conflict in the family, you would err on the side of continuing to provide treatment to this patient till the terminal end of the time comes. for this patient. So as a physician, yes, you would want and give this patient treatment. It doesn't seem that she is suffering from a disease in which, not suffering from cancer. There's still the possibility, even with this scenario, that she may have a small chance of coming out of this. So as a physician, I will take the responsibility.
There's the Islamic perspective, the legal Sharia perspective is that you also have to decide whether the treatment is actually helping the patient or not. So for example, if this lady, because I don't know how the words are written on the board, so if the patient is in a position where the treatment is actually helping the patient, or is it just fulfilling the doctor's own moral and ethical value? Because I don't want to do it, and that's perfectly fine. The doctor shouldn't be doing it. But the thing is the Sharia perspective on this is that if the patient is actually being helped, and you go for the further treatment. As a layman, this looks pretty bleak to me, actually, as a layman. And if it's that bleak, that there's hardly any chance, sort of a miracle, that the patient is going to survive that, then you let him go on what we usually call tender loving care. That's the Sharia perspective which I've researched for this.
Anybody from the audience, please do step in and say things, because it's not just us here, the panelists, it concerns all of you. So during these things, if anybody has a comment.
Regarding the previous scenario, इसमें what we are not looking at is that जो हमारा primary जो treatment है वो patient के लिए है. Again, if the patient is futile, treatment is futile. Should we continue with the treatment based on the fact कि उसके attendants कह रहे हैं करते हैं? As a doctor, our primary responsibility towards a patient.
In the absence of any true intent from the patient, the next of kin are legal representation of that patient. So you must adhere to their wishes. Yes, you understand it's not going to take you anywhere, but legally speaking, you just cannot stop without either from the consent of the patient themselves or their next of kin.
But you see,
इस केस में ना थोड़ा सा उस तरीके से मैं जाऊंगा गदेल साहब के साथ एग्री करते हुए कि कोई भी ऐसी डिजीज एग्जिस्ट नहीं कर रही फिलहाल जिसको कि हम कह दें कि रिवर्सिबिलिटी में नहीं. अभी दिस पेशेंट may have, for all I know, hypokalemia, hypocalcemia, जिसकी वजह से वो रिकवर नहीं कर पा रहा. And I might think कि भी ठीक है, at this point, even though the age is against this patient, but overall survival, but still there is no cut and dry scenario which says that this treatment will not take care. ये ठीक है, चाहे वो मुझसे के लिए इंतजार कर रहा है, लेकिन इसके ऊपर हमें थोड़ा सा सोचना पड़ेगा क्योंकि we cannot deny the treatment, we cannot withhold the treatment, we cannot remove the treatment in this case scenario from my point.
But there's a question, can I ask you, the doctor? For my education, so we have, for example, in Pakistan, we have limited resources at the government hospitals. So I've got one ventilator, and I've got this, what the doctor said, futile or near futile patient, and I have a young man who's a healthy person who can easily recover within a few days. Who do I give the ventilator to?
देखिए, मैं गवर्नमेंट सेक्टर में बैठता हूँ, मेरे पास ICU है, वहाँ पे टोटल 7 बेड्स हैं. अब 2000 पेशेंट्स एडमिटेड हैं. एक्चुअली तो 20% मिनिमम रिक्वायरमेंट है किसी भी हॉस्पिटल को हॉस्पिटल कहने के लिए कि 20% से कम ICU बेड्स नहीं होने चाहिए. सो गवर्नमेंट चाहे जितनी मर्जी टाइलें लगा ले, लेकिन अगर जब तक के इनकी जो बेसिक गवर्नमेंट की रिक्वायरमेंट है ना उसको ना फुलफिल करे तो पेशेंट ऐसे सफर करेंगे. अब हमारे ICU के अंदर मैंने मेड बी राइट और रॉन्ग, हमेशा ये कहा हुआ है अपने सीनियर रजिस्ट्रार्स को कि यू गो एंड इवेल्युएट एनी एंड ऑल पेशेंट्स and look at them as a priority wise. Any disease that is recoverable, any patient whose life is of any kind of value to the value in that sense कि 40-year-old है, निमोनिया के साथ आया है, एस्मा की वजह से वेंट पे जा रहा है, उसको वेंटिलेटर अवेलेबल है या नहीं है, इंट्यूबेट कर दो। इंट्यूबेट करने के बाद या साथ वेंटिलेटर नहीं भी है तब भी उसके साथ बैठ जाओ और उसको एम्बू बैग के साथ चलाए रखो। यू नेवर नो 2 दिन के बाद वो वेंटिलेटर की रिक्वायरमेंट से उतर जाए। अब 2 पेशेंट हैं, एक वेंटिलेटर है, एक 88 ईयर है और यही पोजीशन है वर्सेस एक 34 ईयर ओल्ड है, निमोनिया और रेस्पिरेटरी फेलियर के साथ आया है। अब बाय डिफॉल्ट that patient one ventilator अगर available हो जाएगा तो वो उस तरफ को चला जाएगा। This patient family, if they continue to insist, they can continue to insist, we can continue to provide whatever resources are available, even with the intubation, ambu bagging, electrical shocks. I'm fine with that. I don't have any, I would not refuse the treatment. But दूसरी साइड वाले के लिए अगर मैं किसी तरह से इवन मेरे पास अभी भी पेशेंट्स हॉस्पिटल में एडमिटेड है जिनके पास आईसीयू बेड नहीं है, वो इंटूबेटेड भी है, उनको एम्बू पैक पे चलाते हैं, हम 2-3 दिन चला देते हैं बिकॉज गवर्नमेंट के रिसोर्सेज जो है वो टाइलों पे लगे।
So we have an index, so we have a standard